Check, check.
I like that. Now it's on. Oh, okay, got it. As we're just getting settled, if you are a speaker for this session, please come on up and sit on the podium here. I'll sit down here. We're going to have everybody scoot down just a little bit to make room for one more speaker. She just went outside though. Yeah, she's outside. I think. Huh? No, we're good. Thank you. I think, well, Purvi might be outside. Felicia. So she's right there. Huh? I brought your stuff up here. No, it's okay. Well, good morning and welcome to our diversity, equity, and inclusion session discussing community-based HPV surgery and how to build it. I am Monica Dua and this is Stephen Cunningham, and we will be your moderators for this session. The idea for this session actually came out of the DEI climate survey that was sent earlier in the year to our members, and this really helped us recognize that we can work on supporting our HPV community surgeons and really trying to increase their representation as members, as panelists, as speakers, and as leadership roles. So just for some numbers in general from our AHPBA membership, we have 15% community surgeons. And I suspect that those community surgeons that are members are actively involved. So we're happy to see that some of them represent our executive council. So we have 17% of community surgeons on our executive council. And for this year's 2023 HPBA, the invited program, we do have 20% of community surgeons that are participating in the invited program. But obviously, we'd like to see that increase. So with that, we hope this session is useful not only for those transitioning to community practice, but really to increase collaborations between academic and private settings and really encourage more of our community surgeons to stay involved with this society. And with that, we'll have Dr. Cunningham introduce our first speaker.
Good morning, everybody. Our first speaker will be Dr. Purvi Parikh. Dr. Parikh is an HPB surgeon and surgical oncologist at Rochester Regional Health, based at Rochester General Hospital and Unity Hospital. She also has a degree in clinical science investigation and has published numerous research articles and book chapters and is nationally recognized for her expertise.
Thank you very much, Stephen. So when I talked to Monica about this, I said it's interesting that I got asked to talk about compensation models and negotiating salaries because I don't do a really good job of it for myself. And, as someone who's probably been in the community for a long time, I started out at a small academic center and then a statewide academic center, which was more run like a large community hospital, to then in an HMO kind of setting. And right now I'm at this hospital-based, broad-based community practice. And what I've noticed about that is that it's quite different than how universities work in how you're compensated, what you're compensated for, and what you need to negotiate when you take a position. How do I change my slide? Is it this one? Okay. So when it comes to compensation models, I kept it really light. Monica was like, okay, 3 slides, something short. But compensation models are really different. They can be RVU based, they can be collections based. Some are charges, depending on how many charges you do, you get a percentage of this charges. But most of the places I've ever been, it's some sort of combination with some sort of formula that's put into play. Are you a certain amount of RV? Do you have to hit a certain amount of RVUs and then you get an incentive depending on that? And is that incentive the same base salary RVU that you're making? Is this based on how many collections you're getting and then a percentage with overhead taken out? Or is this basically because they're looking at the work that you're doing is just from the charges and they're doing a certain percentage of charges? I think the charges thing and getting a certain percentage of charges there's very few models like that. Most of them have to do with either RVU, especially in a community-based setting. Oftentimes when your patient, depending on your patient population and the difference in like, what I would say is the type of patients and the insurance payers and stuff that you get. So that's a little bit different on how they do that. There are certain community hospitals, which I call them the Ritz, because they're so nicely done. Everyone that shows up there has insurance. It's all private practitioners and private setting where it's a lot of insurance, good insurance patients that come there. And then there's community hospitals where I'm at, where the community hospital is significantly more in the community, where it's a lower socioeconomic status volume of patients that come in, where then they do more of an RVU based type of compensation. And usually when you go in, you want to have a discussion about like, how is this going to be in my contract? What is my expectation for the base salary that you're giving me? And then what more can we do to increase those compensation models? So when it comes to negotiating salaries, I always say, everyone wants the highest salary. Every doctor, when they go in, they try to negotiate the highest salary because who doesn't want to get paid more, right? So, but salary is more not just on your base salary, but it's also, when the base salary comes in and you go in to negotiate, make sure you have appropriate like gender equality. Look at the regional areas that you are. What are people getting paid? It's surprising to find out that, the region of the Midwest oftentimes gets paid significantly more than the East Coast or the Northeast does compared to other areas. So you want to definitely look at the current market rate in the region that you are at. You want to make sure that they're paying appropriate for gender. There's not a gender bias, which is really hard to kind of sometimes find out, but looking at and comparing models, which is actually really important. And then looking at academic versus community-based salaries. There's Most community-based salaries don't include anything that's like, oh, I'm an assistant professor, even though you're maybe an adjunct professor to your local university or something like that. But there is a way, if you're having residents or medical students, to negotiate that into your salary as well. Especially if you're spending some time teaching them, whether they're in the operating room or participating in lectures in the morning and stuff, and that can be incorporated into a certain part of your salary as well. Then you'd want to talk about incentives. Are you going to get paid for call? Are you going to, if you take trauma call or help out on the trauma service, are you going to make more money for that? If you take weekend call or in-house call for general surgery and ER call, is there more money for that? And then your incentives, as in like, if this is the RVUs that you expect for my base salary, then if I hit more RVUs than that, how are they, what are the incentives of getting paid for that? What rate will that be at compared to the rate that you would get for your base salary RVUs? So that's something to also think about when you're negotiating. The other thing is when you first take a job, you always think, well, of course they're going to supply me with a nurse. Like, how could I, of course they're going to have a secretary for me. Of course they're going to have an access associate for me. How else will my patients get in, right? But those are things that oftentimes have to be negotiated. Do you need an MA? Do you just want an MA? Do you want an LPN? Do you want an RN? Do you want a nurse navigator for cancer stuff? Do you want a PA or to help you on the floors? Who's going to help with the floor work? Who's going to help with overnight call? All those kinds of things that kind of need to get negotiated, and they don't make up part of your salary, but they are part of your salary because that is an expense that the hospital is putting out for you to help with your practice. So those are definitely things that need to be negotiated into administrative time. If you're going in and to build a new HPB program, oftentimes, you need more administrative time in the beginning that require you to set up your, how you're going to do your referrals, how you're going to set up your program, all that kind of stuff. So are you going to get an administrative bonus, administrative support? Do you have like an executive secretary that could also kind of help with that kind of stuff, as well as managing your calendar? And not just your operative calendar, but also your regular appointment calendar. So there are two separate things that you need for that as well. So you want to negotiate those things as well. CME, conference reimbursement, that is something, depending on how many conferences you go to, how much CME you're planning, that you're not just wanting CME that's like hospital-based CME, but you're actually wanting to go to meetings, you're still wanting to present at meetings, how much notoriety you're going to bring to your community hospital by going to national meetings and presenting how things are constructed there and how you're going to be doing. Those are all things that also get negotiated into your salary, as well as other educational options. Do you want an executive MBA? Do they have an affiliation with a university where you can get a discounted tuition? Would they be willing to pay for tuition? What percentage of it? All that kind of stuff can also be negotiated into your salary. And then room for growth. Are you able to hire someone else? How many people do you feel like you need to be hired? All that kind of stuff also gets kind of negotiated into that package and salary package that's all included. So this is a very negotiating salaries, compensation models. Every time I felt like I've negotiated something, I've gone in with the compensation model I like to use, and they always have a counter one for some reason that shows less money or less something. So it is a lot of back and forth and discussion of the things that you need. It's a lot more of a balancing act. And for someone who's been to several jobs and negotiated, it's every time the negotiation seems different and harder. So it takes a lot of practice.
Great. Thank you so much, Dr. Parikh. That was great. The way we're going to run this is we'll have each talk, and then we'll have an opportunity for questions after each talk. And then at the end, if we have time, which we hope and think we will, would like to have some small group discussions. So any questions for Dr. Parikh from the audience?
this thing working?
Yeah.
So when I look at the MGMA or the ACGME data, there's no category for HPB surgeon.
Right.
So how do you decide what to expect how do you assess what is fair market, value or fair compensation for a specialty that isn't really covered? Because it's not general surgery.
Right. So that's actually a really good question. And that comes up quite a lot. At Kaiser, which, I learned a lot from on negotiating salaries and how salaries are determined. We used to look at this. There is a thing for surgical oncologists, which isn't quite HPB either, because they involve a lot of breast surgeons and a lot of thyroid or endocrine surgeons also into surgical oncology, which don't always make it as relevant. Oftentimes, we would look at the thoracic surgery model and what they were getting paid at, or because most community hospitals don't have a liver transplant or a transplant program, it's really hard to negotiate a transplant salary. So we would do something in between a transplant and surgical oncology, finding a median between that or a mean between that for a salary based on rank is what we would usually do.
I just wanted to make the comment that one of the things you should all watch for very carefully, and maybe Dr. Shoup can comment on this, is being very careful about unlisted codes. So some centers will state like a 48999, which is what you've got to use for a robot Whipple, for example, might go to an RVU rate that is very low. Zero, exactly. So I would recommend that you really look at the unlisted codes, especially if you're trying to push your MIS practice. And what I would recommend is looking at the open code with an augmentation based on that. So, use a 48150 with a 20% org because it's a difficult case. And the center is getting paid for that DRG, don't forget. And they're saving on that because that distal pank's going home in 2 days as opposed to 5. So you should really be smart about this. And those unlisted codes will really get you, right, Margot?
Yeah.
So I was just going to mention this one thing about the unlisted codes. At our institution, what we did is we made a list of dummy codes, meaning what wasn't able to be coded because it didn't have an appropriate code. We assigned those a code and then an RVU that we thought was appropriate for those codes. So then when they would go to bill for those dummy codes is what we would use to bill for them because with the assigned RVU to it.
Yeah, I see that work as well. I think that you have to really sit down with your finance team as soon as you get there and make sure that's working for you. Otherwise, it's going to be hard to catch up later.
We do have a couple of questions from the floor, but before you ask your question, I just want to add, we did have here at the HPB a few years ago. In fact, Purvi, I think you invited me to give it a talk on building an HPB, and I'd be happy to share that with anybody if you would like to email me. Please go ahead.
Kim Washington, I'm in Fort Worth in a community practice. My question is the fact that we are training a lot of HPB fellows and whatnot, and a lot of them are going out into communities where they're being asked to build a HPB program, which is my setup. So how would you recommend that those people negotiate salaries when they're actually coming in to build something, not just coming in to work? Because I think that element of stress and organization and all of that should also have a dollar value.
Maybe that should go.
So I do think,
That'll go into your.
I think that's part of what you're going to.
The next
Margot's
two
gonna-
speakers will address that
Yeah.
from the hospital
There
and
you go.
physician side. So maybe that's a great segue.
Standpoint. We can ask that
We'll have
question
Dr.
after.
Clark.
Sorry, I just have one quick comment. So actually getting access to these numbers, either the AAMC or the MGMA numbers is actually quite expensive. What the American College of Surgeons has done is they've tried to make it more accessible to everybody. And so if you go to the ACS website and look for advocacy and employed surgeons, you can actually request a discounted subset for your particular field. So I think the whole report's like a couple $1,000s for MGMA. I think for $45, you can get the AAMC numbers. And then for the MGMA numbers, you can get it for like $250. They'll just send you the subset of whatever specialty you want. So I think that's been really helpful to make sure that everybody has access to these numbers so that you know what you're asking for when you go in.
I agree.
I'll
Great,
do you
thank
one
you.
better on the MGMA. If you're institution subscribes to the MGMA, you can go on the MGMA website with your institutional email address and you can get the data for free. You can just sign up for it. I did not know that. And one of my colleagues told me, oh, I wanted to try, I was going to buy it. And I went on their website and then they sent me an email and I registered and then I got access to the whole data set. So it's actually you as an employee of the institution that subscribes can get access to that data and you don't have to pay for it for MGMA. I don't know about HCGME.
Do together? Yeah. Okay, I think that's a great segue into our next talk, which is negotiating for hospital and institutional support. And we're lucky to be able to present both sides, both the physician and hospital side. So from the physician side, we'll have Dr. Nelson Royale. Dr. Royale is a hepatobiliary surgeon at Northeast Georgia Health System in Gainesville, Georgia. He completed his HPB fellowship in Cleveland Clinic and has led the development of both mixed community and academic HPB programs, including the integration of mixed private and employed physician multi-specialty teams. His practice involves both open laparoscopic and robotic techniques, and he leads the gastrointestinal research interest group at Northeast Georgia Medical Center. Welcome.
Thank you for the opportunity to present. All right, so I'll try to give my perspective, and this is not universal. I think the challenge is every community program is different, and you're working with entities that have their own priorities. But basically, whether you're coming out, I think people that go into community are probably brand new fellows, and this is probably the worst time for you to do this. If someone's experienced in HPB, then you're just focused on building a practice in an academic setting. Whereas if you're going into the community, you're being asked to build not just the practice, but also figure out your early career, which is really challenging. So when you're evaluating jobs, and that's kind of where I was in my situation, I start with kind of looking at a needs assessment. And so that starts with looking at my own personal needs. You know, what's your lifestyle? What kind of practice type do you want to have? What things do you want to do? What don't you want to do? Do you want to do transplant? Do you not want to do transplant? Do you want to do HIA pumps, whatever? Then look at the institutional needs. So what does their current general surgery practice look like? What's their trauma surgery practice? Are you going to be taking emergency general surgery call? Are you going to go to multiple hospitals? Do they have interventional radiology support? Do the guys that are doing interventional radiology already do tips? Do they want to do stuff like that? Are they going to work with you and learn the things along the pathway? And the same thing goes for your interventional GI colleagues. When I started in Tulsa, the interventional GI guys barely felt comfortable doing EUS guided biopsies, but the goal was to get towards endoscopic nephrectomies and all the other interventional needs that we're going to need in HPB surgery practice. So you have to have partners in other specialties that are interested. And then otherwise, your institution is going to be looking, how can we avoid longer length of stays for these patients that we're dealing with? How can we avoid readmissions? And how can we facilitate other practice growth in addition to your own when you start out? And then the regional needs are going to be things like improving access to care, providing underserviced care to groups that can't travel out of the region, and then reducing reliance on maybe outside neighboring communities. And then after that, I kind of look at shared goals between us and the hospital system. So like the physicians groups, usually we want to provide a standard of care that's not being provided currently, or we want to improve regional education in our subspecialty diseases. We may want to participate in national health collaboratives that we're not currently able to provide and recruit additional staff over time. From the patient side, they really just want the optimal care. They want better access to the care. They want earlier recognition of certain types of diseases in our HPB world. They want a safety net coverage for when they do travel to the bigger centers for their very subspecialized care, to have someone locally who can care and recognize emergent complications or recurrent disease without having to travel suddenly. And then administrators really want to reduce costs. That, I think ultimately that's their goal. It's kind of black and white. They want to improve operating margins. They want to improve high value patient recruitment. You know, if you're going to recruit all uninsured patients, that's probably not of significant value. They want to know that they're improving their mixture of payer source. And some of them are going to try to leverage your success for their own promotion. And so remember that when you're working with these people, they're going to tag onto your coattails for your success or your failure. And ultimately, it is, as time goes on, they want to avoid additional workloads. So if you find that you're constantly making their life harder, they're not going to want to work with you. And which is, it should be obvious, but And then the last part is really kind of defining the barriers that currently exist to all those things that you just talked about. So it may be financial. That's usually what we think about. How much does this equipment cost? How much does nursing certification or recruitment cost? How much does extra OR staff cost? You know, when you talk about having a specific HPB OR team, that is a huge cost to a system, and it may not be feasible in your first job when you're doing 20 Whipples in your first year. That's not feasible. That's feasible at major academic centers, but that's not feasible in the community. And then imaging costs. So if you have specific imaging needs and you're asking them to create protocols and train techs, that is time and cost that you're asking them to do. And then the other part is if all of a sudden you're going to switch paradigms, like all of a sudden you're going to start giving this new immunotherapy that they have terrible margins on, that's going to be a negative to your program overall when they look at you. Personnel requirements, you know, you have to include recruitment for these personnel. If you live in an area that is training nurses and APPs, that's great. You can burn and churn through them if you have issues establishing your practice or you overwork them. But if you're in a rural setting that doesn't have access to these people, you've got to retain people no matter what. And then the education part of it is really your own education. Very few fellows come out being confident in all aspects of HPB. You know, when you talk about catastrophic management that was at the talk given yesterday, I don't know that a lot of fellows coming out feel confident controlling major massive bleeding and liver resections. If you have a suprahepatic cable injury, if you have a retrohepatic cable injury, I don't think every fellow knows all those moves coming out. So you need to identify what your gaps are going to be. And if you want to have a specific type of practice, what do you need to learn over the next couple of years, and make sure you have the setup to do that in your practice. And then lastly, as you get going, is monitoring your results. If you don't track your results, someone else is, and they'll tell you, and it may be wrong, but you're going to have to answer to that regardless. So make sure you align with your administrative staff who are tracking these outcomes. It may be a quality director, it may be the CFO. You need to know your data. Ask for monitoring for monthly operating reports that they're looking at. If they're using a quality data system, it doesn't matter if you agree or disagree with that system. You need to be following the same data that they're following and optimize your outcomes and your results for them.
We're going to go right into the second part of this talk, which is the hospital side, presented by Dr. Margot Shoup, and then we can talk about the questions at the end. So Dr. Shoup is president of the Orlando Health Cancer Institute, and besides her esteemed surgical training, finishing surgical oncology at Memorial Sloan Kettering, she also earned an MBA at the University of Massachusetts in Amherst. In her current role, she oversees 11 sites and is the principal investigator on several nationally funded and investigator-initiated research trials. She has served as the president of many surgical associations and currently serves as the president of the Western Surgical Association.
Thank you. Short enough that I can't see that. So this is not mine. This is not my talk.
This is negotiation of hospital and institutional support, part 2. Tryout is probably.
Yeah, it was uploaded this morning. So I'm just going to get started then. My first slide says administration is not the enemy. I mean, I'm one of you, I'm a surgeon too, but I had somehow fell into my lap to take this administrative pathway almost because I enjoy it. I feel like I owe it to all of you to be your voice, to help us get what we need as surgeons, to help develop programs. But the reason I say that is because just like as surgeons, we have a job to keep our patients safe. In administration and the financial side, they have a job to keep the hospital financially safe. And this is really important. So if you look at today's world, the majority of healthcare systems out there actually lost money last year. The average operating margin for large healthcare systems was minus 4%. That means they lost 4%. Think about that if that was your own personal savings and you lost money. And what's happening is many of these systems are digging into what they're saving. So if you read about days of cash on hand, that's how many days can the hospital survive with absolutely no revenue coming in. And those are shrinking, which means they're digging into their savings to pay for our operations. And having said that, everybody who is in charge of running a hospital system, healthcare system, is interested in developing programs that are going to be beneficial financially. I mean, so it's not all about money, but without the money, you can't build the programs. And so that's where I come to thinking about what it is that they're looking for in an administrative role to help you to get what you need for your HPB program. And there's several things, and one is wish I had my slides in front of me, but one of is looking at sort of what Nelson had said earlier, the financial viability. So first of all, there has to be a need. You have to document that with your healthcare system, just because you're good at it and you want to do this program, is there a need for this program? Is there a need in the community? Who is your competition? Who else is doing complex HPB surgery in the community where you are? And is there really a need? And that's number one. And number two is put together a really robust business plan. So what is your return on investment? What does your SBAR look like? What does your pro forma look like? And is this something that makes financial sense? So if yes, there's a need, and yes, it makes financial sense to do this. And then finally, believe it or not, you as a leader plays a huge role in whether or not someone's going to invest in a program. Whether this is philanthropy or program development, they're looking for a leader who is going to be optimistic, energetic, someone that they can trust, someone who's going to be a team player, not someone who's going to complain about everything, but actually is going to figure out how to come up with solutions rather than problems. And that's really the basics of what people are looking for. So if you go back to number one, how do you identify the need? This is where you have to bring in your strategy team. Find somebody in the strategic teams that understand the market share. What is the current market share of liver cancer and pancreas cancer in your area that you have? Looking at your primary service area, secondary service area, and they can tell you the number of patients within your region, within your community, that actually get diagnosed with pancreas and liver surgery. And from there, you can understand where are these patients going currently for their care. And so you can actually come up with a pretty good idea of what your volume could be once you develop a successful program. That's number one. Is there a need? And number two is, what is the return on the investment? So you put together, this is where you work with your finance team. So you can't do all this alone. You have a finance team that you need to identify, somebody that can help you put together a really good pro forma that understands what is the potential investment going to return. That's right. People like to talk about return on investment. Let's see. People like to talk about return on investment, and people in finance are like, oh, you're so cute. You know what ROI is. Go to your Whipples and we'll worry about that. Which is why I got my MBA, because I wanted to know just more about what an ROI meant. But they want to know that what is a realistic return that they're going to experience. If you're losing money every day in your own finances, in your own household, are you going to invest in a program? Maybe, if you see that it's going to pay off in the long run. But this is really important. And so you work with your finance team to understand, what is the upfront investment going to take? What do we think it's going to look like in the first year, second year, third year, and fifth year? And is this something that makes sense for this healthcare system to invest in? And can they invest in it? You want to understand what could be the potential net revenue, which is your collections that are brought in. What is the potential contribution margin, which in a regular business, that's your profit, right? We're nonprofit, so we call it contribution margin. But what is that going to look like, and how is that justified financially? And be realistic. If you really think you're going to do 100 Whipples year one or 100 liver resections year one, great. I think that's not realistic. If you're not realistic as you put these performers together, they're going to start clawing back the resources that they have guaranteed you for them, because they're going to show that you haven't actually been completely honest with it, or the program's not taking off the way you think it should be. But what is it that you need? Why do you need an APP? Why do you need a navigator? Do you need to hire a pathologist, or can you work with the people that we have? Do you need to hire an anesthesiologist, or can you work with the people you have? What is your APP going to do? Are they going to help you round on your patients and reduce the length of stay on your patients? Why a dietitian? No one bills for a dietitian. Are they going to help you decrease your malnutrition and readmissions? These are things that's what they like to hear. Length of stay, readmissions, 30-day mortality. That's a real number that people can grab onto. And so this is has to be very well thought out. And believe me, I run a cancer institute. I don't run the entire healthcare system, but I have people coming up to me all the time wanting to develop programs. Great. He who has the best proposal wins. That's the bottom line. So put together an incredibly great proposal that becomes a no-brainer that this is something that the healthcare system should do. A really strong liver program, a liver resection brings in as high as a $30,000 contribution margin per patient. And you can get that data from a lot of different places. And like I said, for leadership, it really depends on who you are. People aren't going to invest into a program if they don't believe in the leadership. If you talk to venture capitalists, part of what leads them to want to invest into programs is because they believe in the leadership that they have. So it's so important that you are optimistic, energetic, passionate, and be one who comes up with solutions and not complaints, because no one wants anybody who's going to make their life harder. They want somebody who's going to make their life easier. And be persistent and resilient, because it's not going to happen overnight. Whatever it is you need for your program, if you continue on with this pathway of saying, this is, if we had this, we could do this. Without this, I could do this, and show the data. Don't just complain about it. It's really, really important. This is just talking to high level about what we can do. I don't have all the answers. I have been able to build a lot of really great programs. I've been told yes, and I've been told no, and I tell people yes, and I tell people no. But this is sort of the really high level of what I think makes programs work and why they get funded. So if anybody has any questions and want to talk to me, here's my email. Please feel free to reach out.
Maybe one question that we could ask is to circle back to what Dr. Washington said, which was for those just coming out and to practice and expected to build a program and have this business plan, besides you, who would they talk to about trying to actually get information about net revenue and, creating this best business plan?
I've yet to work in a healthcare system that doesn't have a strategy team and a finance team. And the goal is to talk to those people and find out, ask them, who do I go to to help me build this program? Who are the resources that you can give me? One of my other organizations I went to that was a community program, I just made an appointment with the CFO, and he got me in that day. He was so excited to have a surgeon that actually wanted to talk to him about finances that he got me in his office right away. So you just have to identify the right people that can help you, because there are a lot of smart people there, my guess is, and they're there to help you develop these programs.
And I'll add, I like that Dr. Shute mentioned that she went back and got her MBA. You're talking different languages with a lot of the administrative side. And so they're taking the time to learn what you mean by overall survival and readmission. These things are foreign concepts to them. Reducing a pancreatic fistula, they don't get what that means, but they're trying to learn it. You need to take the time to learn their language, which is EBITDA and all these other key terms, and take the time to learn their language, because they're trying to learn yours, and you'll come together at a better point.
While Dr. Washington's coming up, I just wanted to ask Dr. Shute, so many new trainees are hooked in with this amazing 2-year salary line. How do they get smart about realizing that that may not pan out after those first 2 years based on metrics?
Wow, that's kind of a loaded question. So it's not just new trainees, it's anybody taking a job and understanding it might not pan out. I think that, you really sometimes you don't know what you're getting yourself into until you get there. And I think we've all experienced that in our careers. But I don't have the right answer for you, except for just to say that really take a deep dive into other programs that have been successful. And I didn't even mention, I think we forgot to mention that if there are other institutes within your area that have made it work or haven't made it work, reach out to those people and find out what's happening. Because if you're not on track at the end of your 2 years to hit your targets, is that just because it's taking longer than you thought? Or is this something that is probably just not going to work out and you have to be able to figure that out?
Sorry, I have like a million questions because I'm just starting this journey. So the main question, I guess, for you, Dr. Shute, is once you've kind of been on track to build a pretty successful program, and now you're coming to the end of that 2 years and things are starting to get real, how do you renegotiate, or can you renegotiate now that you're more successful than you expected, let's say? And then what how do we take into account all the other things that we've provided to the hospital as well, including increased volume in the IR department, increased imaging, increased labs? How do we take all of that into to account when we renegotiate that salary?
So this is a really sticky subject. The medical group cannot be privy to the hospital downstream revenue for negotiation. That leads to a stark violation. So you have to be very, very careful about that, even though you're well aware that what you're bringing in is going to help with the downstream revenue. I would say that the best thing is to try and find at some point, if you've been able to build a program, say, now I need to bring in more people. I need more of my own time. It'd be great if I could have 1 day a week to help develop this program, and let me have some admin time to do that. Everything's renegotiable. Everything is. And if you're on track to build something great, they might not renegotiate that right away. But down the road, I think you bring your value and you will. Some things aren't, the RVU multiplier may not be, your base salary might not be, but other things might be.
Thanks, Steve Behrman from Memphis. We are in a community hospital, but just started our own general surgery residency. But I think the model that we've had through our leadership has really been strictly RVU based. So my question is, and this really goes to the whole theme of this meeting, as well as all the speakers that I've spoken to. So when you're adding a new partner, a junior partner, I'm getting old, and when you talk to the administrators, they're like, it's all RVU based, but you can't bring in a junior partner. And they're not going to start a practice unless you give them some of your cases up front so they can get established. And then when they do operate, you want to be there to make sure that ensure they get good outcomes. But if you do that, then that's affecting your own revenue. And so my thought has always been to compensate the program rather than the individual. I'm not sure if we'll ever get there. I'd like to hear Dr. Shoup's opinion on that. So how do you bring it? I guess the bottom line is, how do you bring on a junior partner when the hospital is so focused on RVUs and really mentor them so that they get good outcomes? Thanks a lot.
And one way that we've been able to work through this is to do group models for RVUs. And so rather than having an individual say, our thoracic team has done this very well. For example, if you have three thoracic surgeons that are operating at the 90th percentile and you bring a partner in, how's that going to affect them? And so we've changed it to a group model, and it phases in the RVUs for the new person coming in over time. Another one is we've been able to protect the salary for some of our surgeons for a couple of years, knowing that they're bringing partners in. That's a tough call, a tough sell, but if you do it with the right people, I put myself at risk when I offer to do that for our surgeons to make sure that they're going to be productive. But you have the right people doing the right thing, I think it's going to be successful. I don't know if you have anything to add.
Yeah, I would advocate for a group model, because otherwise you're in conflicting goals. You want to maintain your income level, or at least maintain at a certain level, and the institution's just not comfortable with that risk. So a split seems more reasonable.
Okay, and just to stay on track, we'll do one more question from the floor, and then we'll move on to our next talk.
Yeah, a quick question, Imad Asham from Houston. You mentioned the profit margin the hospital makes on a case. What's a good source of information for this? Because I feel as surgeons, we're offering a service, the patient is getting a service, there's no price tag on it. And it's completely in the dark, both physician and patient. And then you have the administration negotiating with healthcare insurers, and we're completely out of the picture. I don't know how much the hospital is making out of my hard work. I don't know how much I'm with. So is there a database, a source we can go to, and some transparency that we can get these numbers?
That's what you need to negotiate to get your monthly operating reports. If it's not on there, what their end reimbursement, and it may take 6 or 8 months or longer to get this, you need to know that, especially for the unlisted codes. They're going to base, ideally, they'll base your reimbursement for that unlisted procedure on what they're actually getting for it. So it doesn't matter if you want to get paid 70 RVUs for a lap Whipple. If they're getting paid equivalently for 20 RVUs, there's no reason they should be paying you 70 RVUs. So you can ask for that data, and I ask for that data on my monthly operating reports.
Yeah, me too.
Great, thank you very much. Our next talk is about advanced practice provider partnership when building your team. We'll have 2 speakers for this topic also. Our first speaker will be Natalia Paez Arango. Dr. Arango is originally from Bogota, Colombia, and is a surgical oncologist at Tri-Health Cancer Institute in Cincinnati, Ohio. She specializes in robotic HPB surgery with a particular interest in colorectal liver metastases and neuroendocrine tumors.
Good morning. So, excuse me. So I'm going to be talking about APPs and partnering with APPs when building your practice out in the community. I have no disclosures. So as the years go by, the US population continues to grow, and with it, the life expectancy continues to increase. So as our population grows and ages, it is expected that our cancer cases are going to continue to increase. So it is estimated that in the next 20 years or so, our cancer cases are going to be up by 50% per population, which is an incredible number. With this statistics, it is predicted that we're going to have a shortage in cancer healthcare providers. And this is, while it is predicted, we're actually seeing it right now in our rural communities. We do not have, where there is a shortage, to the point that our data is showing that patients that are in rural areas or in areas where the density of oncology care is decreased, their survival is impacted. So these patients are actually being affected by not having cancer care nearby to their homes. Not everybody can afford, or not everybody can travel far away to go get cancer care. So what does this mean? It means we need help. We need all the help we can get. And this means establishing collaborative teams so that we can not only provide better quality of care, but we can actually impact survival by having more access for patients. So what does building your team imply? So first, you need to consider what are your needs. Once you establish your needs, you can assess what kind of roles you can have for your team. You need to consider your program development. You need collaboration and communication. And you can also consider whether you want to do research or not, particularly for quality improvement projects. It's one option. So where do APPs come in to help us? What are APPs? APPs are advanced practice providers. They can be either nurse practitioners or they can be physician assistants. And they can serve in a multitude of roles. They can help us with medical history assessment and examining our patients. They can help us not only ordering tests, but interpreting them and performing these tests. They can collaborate with all our other teams in a multidisciplinary setting. They can help us diagnose and treat conditions. They can help us develop treatment plans, prescribe medications and treatments. They can help perform procedures. They can help counsel patients and families. They can educate our patients. They can help us with research and so many other roles. So when it comes to assessing our needs and establishing roles, first we need to assess where and when do you need help? Is it in an inpatient setting, outpatient setting, in the operating room, or do you need help with research? In the inpatient setting, it also depends. Sometimes in community settings, for instance, I have the practice that I have, we have a residency program. So does that mean, do we need help inpatient because we have residents, or we don't have residents and we need inpatient help? Our APPs are our vanguard in the floor, actually, because they are used to, that they know our patients. They are the front line. So they're able to be there while we're operating. And we're not necessarily readily available, but they can be, and they're able to bond with our patients and be able to help us improve quality of care, not only while they're in the hospital, but just help us when we're in trouble. In the outpatient setting, and I'll go a little bit further down, is the amazing roles that they can do in the outpatient setting. And then, of course, in the operating room, everybody has different practice settings. Some people can have APPs just inpatient, just outpatient, or just in the operating room, or they can have a hybrid model where maybe they cross between operating room and inpatient setting. I can tell you, having APPs in the operating room who know what you did in the procedure, and then having that same continuity of care in the outpatient setting is just incredible for continuity of care, really. So program development. now we have more standards that we need to abide with. So the American College of Surgeons, actually the Commission on Cancer, now has standards that we need to comply with for survivorship care plans, prevention, palliative care, preoperative education, and follow-up. So APPs can be a wonderful resource to help us stay on par with what is required of us by NCCN and by the Commission of Cancer. Preoperative education is something that patients absolutely love, because sometimes when we're in the office explaining to a patient what a Whipple entails, they can be overwhelmed. They hear one thing, but they don't necessarily retain. So sometimes what I do in my practice is we have patients actually come in for a preoperative education visit just with our APP, where they can feel more at ease. The questions can be asked in a more relaxed manner, and it just gives an extra layer of patient education so that they know exactly what the next course of their treatment plan can be. So I think this is something wonderful that we can consider. So when it comes to building your team, working with your APPs, and I know Melissa is going to touch a little bit more on this, but it's very important to involve your APPs in your patient care. So not only in your interdisciplinary rounds, make sure that your APPs are involved so that they know that they're involved in our case discussions. Involve them in our regular meetings, not only for clinic setting, but our administrative meetings, so that they know how practices run, what we need, and help us move on. So as conclusion, we need help. We need all the help we can with cancer providers, and APPs are essential to quality of care. So yes.
Okay, thank you so much, Dr. Arango. So we'll move right into the next talk and have questions about this pair of speakers following Dr. Arvide's talk. Melissa Arvide is an inpatient PA at MD Anderson Cancer Center. She is a busy bedside assistant for robotic surgery and also a preceptor at Baylor College of Medicine for the PA students.
Hi, good morning. I first want to start by thanking the HPB DEI committee for asking me to speak about this. So I'm complimenting Dr. Paya's talk on the advanced practice provider partnership when building your team and APP perspective. How do I move on? Perfect. I have no disclosures. But I have had the privilege of working with multiple teams during my time at MD Anderson and been a studious observer. Okay, so now that Dr. Payas has made the case on why we should consider including APPs and when you're building your practice, I'd like to present different ways on how to do that, how to integrate your APPs into your practice, because ultimately the goal is to have them become a part of your team, to have them become an extension of your practice. And in doing that, you're also going to be enhancing our role as APPs as well. So I know she just mentioned, we can work in a variety of settings, and depending on your practice and the needs of your practice, we can be inpatient, outpatient, in the OR, and I do a lot of research as well, but it really just depends on what's going to complement your practice the most, and that takes some communication, some figuring out how your interest aligns to build your practice. All right, so how can we accomplish that? So the best way is really to try to invest in your APP once you decide that would be a good fit for your practice. And this can be very simple as, taking anywhere from 5 to 10 minutes a week just to provide mentorship. This is going to help you try to develop some camaraderie and with each other and build some trust, which is important in really any working relationship. Another way to very easily include your APP in your practice, and frankly, this is one of my favorite ways, is when you go and meet a patient for the first time, introduce your APP, and it can be very simple as, this is my APP, they are part of my team. And what that does is it automatically establishes that rapport with your patients, and it allows for greater compliance and adherence, to whatever therapies or treatments you're trying to explain to the patient. And that's going to help further on as you're trying to provide education to your patients. And then this one's probably, what I consider the greatest and probably most important thing is communication. It can be a little tricky, I think, but I think both parties need to understand the importance of communicating. And this at the beginning, when you're starting your team and building your practice, you might have to over communicate a little bit, and that's okay. Because at the end of the day, patient safety has to come first. That might mean you have to close the loop on several things. And, you need to make sure that you're on the same page. Also try to allow time for teachings and explanations so that you guys can be in sync as you move forward in your practice. So ideally, what you want to try to achieve is what we call optimal team practice. And what this is this occurs when APPs, physicians, and other healthcare professionals are going to work together to provide quality care without the burdensome administrative constraints. This should accomplish being able to leverage each other's expertise in their roles. And ultimately, you will try to trust and rely each other to avoid duplication of work. So in order to do so, please try to set some time to check in with each other, see how you're doing, what's working, what's not working, what can we do better, what can we do to improve the team dynamic, patient care, and allow some time for feedback, allow some time for setting expectations, and some judgment-free discussions, because any type of situation where you're starting to work with somebody else, you need to have that open dialogue. And last but not least, be inclusive. This setting, coming to professional conferences such as HPBA and bringing your APP with you is a great way to learn alongside each other and grow professionally together. Some conferences like this one offer travel grants for APPs. And so it's a great way to offset the costs, especially when you're not from big academic institutions. There's not a lot of money or funding for APPs to be able to travel. These meetings do provide some sort of ways to offset that cost. Another way, as Dr. Baez mentioned as well, is to involve them in what you're doing as well, right? You want to grow as a team. And so involve them in your projects, your research, your leadership activities to really complement your own practice. So get to know your APP, nurture their interests, and hopefully that will not only align, but it'll complement your practice. So big thank you for your time, and a huge thank you to my MD Anderson team, who have really encouraged me and helped me to become the PA that I am today.
Thank you so much. I think it's really great that we've been able to hear both sides of hospital and physician and both sides of building APP partnership. I think our next group of speakers will demonstrate how this partnership can be used to grow surgical volume. So I'm pleased to introduce Dr. Jay Berquist as our next speaker. He is a hepatobiliary surgeon at Hillcrest Medical Center in Tulsa, Oklahoma. I'm proud to say that he completed his 2-year hepatobiliary fellowship at Stanford with me and my partners, and his career has really taken off using minimally invasive approaches. He is the leader of the robotic liver surgery program at Hillcrest and Utica Park Clinic, and he's working with his nurse practitioner, Sam Kuplicki, who is a certified first assistant with 7 years experience as a dedicated robotic assistant and also works at the following 2 locations. She is a member of the Oklahoma Association of Clinical Nurse Specialists and the Association for the Advancement of Wound Care.
Thank you, Dr. Dua. So when Dr. Balance new technology with a high volume practice, really, I think the topic is it's written in a generic way, but it's more about how to build a robotic program. So that's kind of what I'm going to talk about. And I want to echo, I really agree with everything that was just said in the last talk about building a relationship with your APP. And that was why I wanted Sam to be able to participate in this talk as well. So I only have one slide. Hopefully we can stick to the schedule. But I think the first step, which echoes a lot of what was just said, is, really try to build a team. And something that I've talked a lot about with other people at this meeting actually is as you're taking on more challenging, complex robotic cases, I think it's a challenge for a lot of people to find a way to have an assistant that is reliable and consistent. A lot of people are using residents or maybe using a partner as the person who's doing the assisting. And something that I actually observed as a fellow was that we had a dedicated robotic assistant who was a PA. She's here at the meeting too. Sabrina is her name. And she really provided that sort of continuity, and I think allowed for people to be comfortable taking on, more complex robotic cases because they weren't relying on a resident to do the assistance. And it's a lot to ask, honestly, of a trainee to be at the bedside for a long, complex case, because they want to be at the console and learning about that part of the program. So I think building a team that includes a consistent assistant is super important. And I think part of the way that you do that is by doing cases with that assistant that are lower stakes to start and sort of building up to your more complex types of cases. Something that I observed in my current hospital, which really had nothing to do with me, it all was put in place before I got there, but it was incredibly smart, is the cultivation of a culture in the hospital of technology adoption. So when the robot was brought to my hospital sometime in the mid 2000s, the surgeon who was in charge of that really was adamant that the robot would be used anytime by anybody, and every tech and every circulator was going to be comfortable with the equipment. So if you want to put a robotic case on at night, you can do that. If you want to put a robotic case on Saturday, you can do that. If the robot is available, you can use it. And so I think cultivating that culture of expectation that this is a tool just like any other tool in the toolbox is really important if you want to build a robotic program. And I think other institutions actually have done that, although I don't know how much they talk about it. I talked to a colleague who trained at Memorial, and he said he felt that they were very smart about how they did it. They basically expected that, everybody, when they brought it in, they said, everybody's going to use it. Everybody's going to learn how to use it. And I think that's really important. I think building your volume is an important step in, building up to more complex cases. You have to do a lot of simple cases. And I think, the people at the training courses and things, they'll all tell you this, Martini and those guys, when you go to a training course, they will say, do lots and lots of simple cases, because that's how you develop your comfort and your team's comfort with the instrument exchanges and all of those things. So I think don't be afraid to do simple cases. Don't subscribe to the criticism of, do you really need the robot to do this? Well, if you want to build up to doing complex things with the robot, you have to do lots of simple things with them first. So I think that's really important. Our rep, and I don't have any disclosures, I should have said that at the beginning, but I don't have any disclosures with Intuitive, but our Intuitive rep offered me the opportunity to do case observations for the types of cases that I wanted to do. And we found a person that offered that about a 2-hour drive from where we live. And we did a couple of case observations, and that I found really helpful. And you think to yourself, well, I did a good fellowship. I did a bunch of robotic Whipples in fellowship. I don't need to go do case observations, but you can learn a lot from doing that activity. And I found it to be extremely valuable. So I think that that's an important, part of building a complex robotic surgery program.
I think every time you go and you observe somebody else doing something, also you can see things that you wonder why you didn't learn before, and sometimes cut significant amounts of time off of your preparation and operative time, so you can further incorporate those. I've worked with general surgery for 6 years before I did a hepatobiliary, and was able to go probably 6 to 7 times for trainings, case observations. And even when we just went to the dry lab with Intuitive, I learned something new. And so it's, if nothing else, if you have an assistant you can bring to the case observations as well, it's never wasted. You always learn something.
Yeah. And I think bringing your assistant to the case observations is also just critical, because then you get that time together where you're not operating, you're just like taking notes, asking questions, thinking about how you're going to apply what it's a really high density learning opportunity. And then honestly, the next step after case observation for me was, we asked the person that I had observed to come and proctor some of our early, complex cases. And I can't overstate, this was again, something that like, maybe there's a stigma. Oh, I'm a board certified surgeon. I did a great fellowship. I'm very experienced. Do I need a proctor? Maybe not. But honestly, the proctor gets paid for by the company. You don't pay for it. And it's like having a coach in the operating room. To be honest, it gives you a lot of confidence in your ability to get through the case quickly. And the other thing that's nice, I think a lot of people may be at institutions where it's like, oh, my senior partner could proctor me. And yeah, that's maybe true. Your senior partner can also just take over the case. The proctor won't do that because the proctor isn't privileged at your hospital. So they're going to come, they're going to make suggestions. They're going to observe what you're doing. They'll tell you when your retraction isn't right. They'll tell you how to get better retraction, get better setup, but they're not going to take the case for you because you have to do the case. And so I think using a proctor, especially in your early series, I found it to be super helpful. And I frankly think that it really reduced the operative time on, our first robotic Whipple was, we were out of the room 7.5 hours after incision. And I thought that was great. And I think a lot of it was due to the proctor being there and really helping us go through the case in a way where I might not have been as assertive. I might have been more timid, and it would have taken longer for sure. And then the last thing I think is really important, and this has been mentioned in some other talks at the meeting, is measure yourself. And by that, I mean, keep a case log and track your outcomes. I think that's super critical. Everybody has to do it, no matter what kind of practice you're doing. But I think particularly as you're trying to go to administration and justify, financial things like we've been talking about cases, you need to know, what is your length of stay? What is your readmission rate? And how does that differ between your open cases and your minimally invasive cases? And so then you can really quantify, and you're in control of that data. Because I don't know about the rest of you, but my hospital system, they can give you really ungranular, sort of like high level data about what the average length of stay is for, say, the general surgery department. They could maybe do a thing where they look by CPT codes and tell you what the length of stay is for a given CPT, but they can't tell me my personal length of stay. And they can't tell me the difference between the minimally invasive and the open cases. Only you can really gather that data, which is hard. It takes time. But I think it's worth doing, especially if you want to have leverage in negotiations. Because if they see that you can come with your own data and say, look, this is the difference, then I think that's a really powerful argument. It's hard for them to refute. So did you have anything else, Sam? Awesome. Thank you.
Okay, thank you very much. I think in the interest of getting back on track, we're just gonna go right into the next talk and we'll have questions afterwards. Our next topic is developing a research proposal and will be given by Dr. Babicki. Dr. Babicki is a surgical oncologist in private practice with the Oregon Clinic Center for Advanced Surgery. She serves as the medical director for the Hepatobiliary and Pancreas Center program at Providence Portland Medical Center, and is also the Hepatobiliary Fellowship Program Director with a strong background in basic science research.
Thank you very much for this opportunity to present. I have no disclosures other than to say I'm in my 5th year of clinical practice now. 2019 was getting my feet wet, 2020 was COVID. And so for the last 2 years, we've really been digging into our quality work. And so a lot of this is really preliminary. But today I'm going to discuss the importance of quality in community HPB surgery, share some of our strategies for updating the quality metrics we look at our hospital system, and discuss how you can turn these quality projects into research projects. And just a caveat, this talk is not intended to show our data, but rather just to discuss our methodology. So we have an annual HPB steering committee meeting every October, and I always start by putting up this slide. My mantra is that clinical excellence comes first, but I always make the point that our commitments to research and education are equally important, and there's a lot of overlap in this realm. This meeting is attended by our hospital administration and Cancer Institute leadership, and I really pushed to broaden the involvement in this meeting to include my colorectal and foregut surgical partners, all of my consultants, the GI docs, the IR docs that we work with, the medical oncologists and pathology. And it turns to include the fellows, the NPs, the RN navigators, as well as the research team and the marketing team. So we all have a big discussion about what we're doing and have aligned goals going forward so that we can all be on the same page and work together. So when I started looking at our quality initiatives, I went to the data. This was a really nice systematic review published in 2021, looking at what the quality performance indicators should be for HPB surgery. There's ongoing work at the international level, both with the AHPB and the IHPBA, to really define what appropriate QPIs are. But it's important to point out there's very few universally agreed upon, let alone validated measures. And so this is ongoing work, and I check the literature about once a year to see what's happening. From this paper, they really nicely define some of the studies that have looked at these QPIs. You can see it's pretty well developed for pancreatectomy, less so for major hepatectomy, and it's pretty simple and straightforward for some of the common lap chole procedures or complex biliary procedures. And they really break this down into 3 categories: infrastructure, physician, technical aspects, and documentation. Now, when I started, the measured quality measures we really had were morbidity and mortality, and we had very generous benchmarks that we were trying to meet. And I thought we could really make some of these QPIs more granular. And so we sat down as a big group and discussed which ones we wanted to include in our metrics. And you can see some of the ones we chose to look at were here, and we highlighted in yellow. So we did this for infrastructure. We did this for the physician characteristics. I thought measuring our pancreatic fistula rate was really important, and I wanted to make sure we were able to capture that data. And similarly for documentation, we had implemented already a synoptic op note for Whipple's. We wanted to expand this to distal pancreatectomies. So we really spent the first year with my quality program manager doing a deep dive into our different databases and resources to see how we could capture this data. And she came back with a really nice report talking about which of these metrics we could capture data on and how, and what we would use to be able to get this. And she really put together a nice report of some of our preliminary data on some of these outcomes. And then you can take some of these outcomes and translate them into research projects. So for example, we had trouble finding data on capturing our time from presentation to treatment for pancreas cancer. She really had no great way of capturing that data. And so my nurse practitioner was really interested in this. She's going to do her doctorate for her nurse practitioner degree. And so she's going to take this on as a project and see if she can find a way to capture this data. Our pancreatic fistula rate looked really favorable, and we've done a lot of work with external pancreatic duct stents. And so my second-year fellow has taken on a technique paper and a retrospective review of our data so we can publish that as a project. So in 2023, our goals are really to look at national benchmarks and set our institutional benchmarks for what we're going to measure our data against, and really assess the quality of our data. Is it being accurately captured using the methods we've designed, and is it being adequately interpreted? So some caveats and some early lessons I learned: engage as many stakeholders as you can early, solicit feedback on what they're interested in improving, and make sure you're aligning your goals so you have similar efforts and you can really push it forward on multiple fronts. And identify the needed resources you need and advocate for them. Times are tough. As Dr. Shoup mentioned, costs are high. Hospitals are looking for ways to cut costs. NSQIP is expensive, but our procedure-specific NSQIP is critical for being able to measure our outcomes. And so I advocate constantly for us to maintain access to that. If you need research personnel for your clinical trial enrollment, and like I said, my quality program manager is critical. I meet with her on a quarterly basis, review our data, and she's really helpful capturing all this data and putting it in a report. And beware of overlap. Oncology has their own initiatives. There's the Commission on Cancer initiatives. I have initiatives for my directorship incentives. And if you can just align all of these so you're working on very focused goals and they're applicable across all of these platforms. So thank you very much. I'm happy to take any questions.
Thank you for sharing the incredible amount of work that you have done in establishing outcomes at your program. I want to give time to Dr. Rohan Jayaraja, so we'll come with the closing of our session, which is what the AHPBA can do for you. It is my honor to introduce him. Dr. Jayaraja has remained a mentor and inspiration to me throughout my career. He is the academic chair of surgery at Texas Christian University and University of North Texas Health Science Center. He is a distinguished member of the Methodist Richardson Medical Center, attending staff and director of GI Surgical Services at Methodist and director of the HPB and Advanced GI Fellowship Program. He is our secretary for HPBA, and despite all these roles, still makes time to be an active part of the fellows curriculum through AHPBA.
Thank you so much, Dr. Dua, for that lovely introduction. So I was tasked with the talk of what can the AHPBA do for you? And for those of you out in the audience, to be here as your secretary, I would have never thought this possible. And I'm truly honored to be here. I'm a consultant for these three companies, and there'll be no impact on there's no content relevant. So I wanted to talk about diversity. Dr. Clark has done so much work in this area, and I wanted to talk about my areas of diversity. So I'm from Sri Lanka, grew up in Zambia, great country to visit, by the way, it's amazing. Went to school in London, basically at Hogwarts, and, and then came to America at the age of 18. So boarding school at 14, when I hadn't been on a sleepover in my life and grew up in a very traditional South Asian family, was really traumatic. But it was this diversity of experience that I think makes me who I am. It's great to have something in common with most people that I meet from a geographic sense. It also is amazing that my accent can change really quickly. One of our previous fellows was really freaked out when I walked into a room and I was like, what are we going to do over here, with an Indian family? And then was like, we got to take this thing right out, to a Texan group. My surgical story is also a story of diversity, right? Because I trained at the University of Chicago. I did 1 year of a transplant fellowship, #I'm a recovering transplanter, and then joined the faculty at UT Southwestern thinking that my life would be academic medicine, right? I had that radio frequency chip implanted in my brain like many of you do. And I really thought I fell from grace when I left UT Southwestern after 8 years, had a basic science lab, thought I was doing everything right. And it just wasn't fun going to work. And I promised myself that when that was the case, I was going to change something. And, this is where family comes first. And we were so happy in Dallas, and there were no other academic opportunities available. So I tried to create the best of academics outside of academics. And my practice is a diversity in training, right? So I'm so passionate about this. Those of you that have, I've been involved with from a training standpoint, I trained partially transplant. My practice is surg-onc, really, because I do all sorts of crazy things. I mean, I still do esophagectomies and things. And I run an HPB fellowship, so I am the roadmap to peace. Right. And I'm so passionate because I just think we have so many great things to offer from all of those different tracks that we need to learn from each other. So what kinds of prejudices are there? And I'd like to go beyond what I call visual prejudice to the non-visual prejudice, right? On every committee that I sit on, and this is a very from the heart talk, I promise not to do as I always, I'm so passionate about things that sometimes, please forgive me if I overstep a little bit, but it comes from a place of honesty. Every committee that I sit on nationally, everyone thinks that this is my diversity. That is not my diversity. I'm usually the only person that knows what it's like to know what the internet feed is to my office, because that's what I have to manage. I'm the only person that looks at my balance sheet pretty much every day, because I'm looking at collections and I'm looking to try to find out how we can keep this office open. I may be the only person that applied for a grant through the federal government during COVID and is super proud that we didn't have to lay off anyone. So my understanding, I bring non-visual diversity to the group usually, because nobody else on the ABS or on the ACS really has that deep understanding of what it feels like to have a pregnant employee that you're struggling to keep on health insurance and paying, $10K a month for health insurance, because I can't ethically use health insurance, right? How can I do that? But man, it would help my overheads if I could take that out. So what is academics? And I really think we need to talk about this, because what is academics, right? If you're a busy surgeon in private practice, you're writing some clinical papers. I mean, look at Mickey Babicki, leadership of the hospital, have residents from a local place. So develop those relationships, right? I didn't have medical students, but I grew that relationship. Or if you're a university surgeon, somebody called me about this, great person, well-trained, academic affiliate, has an associate professorship, has no residents there, doesn't teach, has a PA in the OR, and that's it. It's so great to have APPs with us. But when we think about, academic surgery, which of these two people is truly academic? And why do we silo them? So I feel like I don't belong, right? And these are the, we talk about microaggressions. We must respect our community surgeons as they have so much to offer. Well, in some ways, that community surgeons tag can be also a negative thing, right? So we have to use the term, we just have to, but it also comes with connotations. This was something I saw the other day. The beauty of academic surgery is that we can do the type of surgery that heals people. I don't feel so great not being in that space, hearing that, right? And there is nobody in this panel that looks like me. Thank you, Dr. Clark, for moving that needle for us and having amazing people up here that are contributing so much. I still walk into a room and I feel like I don't really deserve to be here, but I'm so proud that I am, and I need to belong. So I just want to give you some hope, right? Because there's so much of the same kind of speakers up there that don't look like me. Not look like me, but look like who I am. I'm your secretary, right? That's a huge statement from this society. This is a guy who has zero pedigree, okay, and is just passionate. I'm your secretary, not because I want the title, but because I want to do something with it. I want to make the world better. I'm a statement that you all do belong. You are really important. You're the future. So let's work together to change the discussion, okay? And that's to move from not just visual, but to non-visual diversity. So let's work on microaggressions and think about what we're saying to each other. In all ways, we're all important. And help me, get on the program. I'm really proud when we looked at the metrics this year, 30% of our panelists and speakers were in non-traditional practices, and that's amazing. But you know what? We can't help you if you don't volunteer and if you don't show up. I mean, I was on the Fellowship Council Accreditation Committee, and it was amazing. People didn't show up to these calls. I showed up to every call and had ideas, right? And before I knew it, I was chair for like 10 years, my God, every Wednesday night for 3 hours. My wife loved that. And so, you really need to think about this, but really be present, have ideas. Don't care if other people take your ideas because you've got more. Thank you so much. Again, this was very much from the heart.
So I just want to make a quick plug for the Speakers Bureau. So we started a Speakers Bureau, which is essentially a collective of individuals that are looking to participate more in HPBA. And you can tell us what are the topics that you are most passionate about talking about or sharing. And it really helps us when we're planning because we don't know everybody. And so this is an awesome way to get involved. We're going to push out some emails probably next week. I want you to look for them and you could talk about anything. Tell us what you do. You know how to build a practice, you know how to set up research at your place, you know how to recruit and retain people, whatever it is. We're always looking for people to speak and talk about not just clinical things, research things, practice building. And it really helps us to make sure that we have broad representation across the country and across the practice types. So I'm just going to make that plug. Please, please, please put your name in and just tell us what you want to talk about so that we can get you more involved at the meeting. Thanks.
Dave Kuby from Atlanta. Actually, I want to just make some comments too. First, congratulations to Dr. Clark for doing a great job with the committee, and congratulations to Dr. Washington. I know the leadership is in good hands. Second thing, this was a great symposium. And so I am that guy who's been in 20 years of more of the traditional academic practice. And I think you made a mistake though. And I think the community-based could have been left off this, because every single talk was relevant to my practice and my world, even though I'm not in sort of a community-based program. And yet I am, because Emory is 10 hospitals. And I'm chief of staff at one of the hospitals that really has been a community hospital. So the traditional academic model is not the same. So congratulations. That's really what I wanted to say.
Yeah, just to add on to that, when I'm asked to give talks for community practice, I look at where I am at Orlando Health, and the lines are so blurred between what's so-called community and academics. What does that mean? I mean, several community practices have residence and fellowships, clinical trials offices, and robust quality programs. So it's just an interesting model. I mean, we don't have a dean or a medical school. I think that's what separates us from some traditional practices. But the bottom line is we're all in it together and we're all here for the same reason. It's just practicing maybe a little bit different model. So thanks, Dave.
I'm Kevin Billingsley from the Yale School of Medicine and the Yale Cancer Center. And, like David and others, I just want to say a really heartfelt thank you to all of you on the podium for putting this together, and our DEI committee leadership. It makes me really proud to be part of the organization. And as a cancer program leader and administrator, one of the things that I will share is that the work that is being done outside of traditional academic centers is incredibly important. And it's very apropos that this is being framed in the context of DEI. As we think about delivering high quality HPB surgical care and cancer care to a truly diverse population and increasing access to care, opening our lens to all types of healthcare organizations is really important. And I think has been touched on here a couple of times. The traditional divides between academic healthcare centers and community or private practices are breaking down. And I would encourage everyone to think about developing partnerships, because that's the future. Those of us who work primarily in academic centers need our community partners. We are developing relationships. We are developing affiliations. The traditional academic model is not going to survive into the future. And the last thing that I would share as a cancer program administrator is that we need surgeons in leadership. I know Dr. Shoup and many others would echo these comments. Much of the revenue into health systems and hospitals come through cancer programs. Much of that revenue is generated through infusion. The medical oncologists actually manage that, but they can't do it without us. And the point that Margot made was important. In your organization, you may not have direct line of sight onto what infusion revenues are, but many of those numbers, at least in a broad scope, are publicly available. And those are numbers that you should have in your back pocket when you develop business plans and negotiate with your health system leadership. So thank you again.
Thank you very much, Dr. Billingsley and Mr. Kuby, for those kudos and that recognition. I think you both are spot on. I think we have time for one more question before we wrap up the session.
Well, I just want to make a quick comment. I'm Mariana Chavez. I'm in private practice in Nashville, and I want to thank the committee and then the speakers for this. I feel like the reality is like I saw your, the quoted tweet that you put in, Dr. J, there, and it makes me feel like, community surgeons, we're coming from big fellowships, well-trained fellowships. And the reality is like, we cannot all fit into academics. First of all, there's no room and sometimes there's not even interest in being academics and just to practice and deliver care to patients and have a balance, you know, family and work life. So I think that we deserve respect, and I appreciate Dr. J's figure in the AHPBA. Thank you.
I just have one fast question. The moniker community, right? We were all standing up here saying community, private practice, like using the quotes. Is it a favorable term? Is it a term that we need to evolve away from? What term should we be using to describe our care teams that are in place outside of traditional academics in a way that's respectful?
Yeah, I think this is really a tough one. I sort of like the hybrid term myself, just because I think even in community practice, there's so many different ways that we are involved in different things. But you're right, I don't know what the right term is. It's just that sometimes people use it disparagingly as, oh, we need to pay homage to our community surgeons. Just to address the previous comment, I do want to say there are things that we do better in the hybrid environment, and we owe it. And we owe it to everyone, like people in traditional academic medicine that are sharing their ideas, to share those things also. So I think that we are responsible for that. And so, Mariana, I just want to say, please bring to us the things that work well in your practice that allow you to have time for your family, right? Because the inefficiencies in traditional academic medicine did not allow me, because I was operating at 9 o'clock at night because the OR was never open. Now I can do 6 cases and be done by 5 and get to see my kids, you know? So we need to share those things too. We owe it. And so that can be academic too, sharing those kind of things within our scope. So I think, you know, one of the other things I'd love to do is to help those of us in hybrid practices figure out how to do what Dr. Babicki is doing and publish the data, how to develop the research infrastructure, because you should be in the OR, but how do you develop those things? So, I mean, just thank you so much from the HPBA for allowing this to happen and to recognize all of us up here as important.